Why All the Ties? A discussion of the identification and treatment of tongue and lip tie in the breastfeeding dyad. Part 2, the Integrative Team. Why All the Ties? A discussion of the identification and treatment of tongue and lip tie in the breastfeeding dyad. Part 2, the Integrative Team. So here's our baby again, that we're wondering if she has a tongue or lip tie. We are currently in a culture where people e-diagnose, share pictures of their babies with others on Facebook pages to ask them to diagnose. And so we're really encouraging a new message that we can't possibly diagnose a tongue or lip tie in a baby simply by looking at their mouth in a picture or even in person. We can't possibly know by simply looking at a picture, because we can't properly assess appearance, function, and fit. In this part 2 of the presentation, we'll be looking closely at the integrative care team, who's responsible for identifying, assessing, and diagnosing suck dysfunction in the breastfeeding dyad, and determining the potential need for treatment and habilitation of the pathological frenum. The presentation you are hearing now was originally given in May in Wilmington, Delaware, with our integrative care team. There's me, Katie Madden, in the center, and to my left are my partners, Gwen and Corinne, the Balanced Breastfeeding Lactation Consultants. And to my right are Dr. Ryan Robinson and Dr. Joanna Green, dentists at Pike Creek Dental in Wilmington, Delaware. Together, we care for our babies with suck dysfunction. I created this infographic in order to visually illustrate the integrative care team. There are 4 components to this care team: those that identify a problem and refer to those who assess, those who diagnose, and those who habilitate. We're going to break down this infographic into its component parts. This is a document you can also download from the main webpage where you got this PowerPoint presentation. So we would like to propose that most healthcare professionals or support people that come in contact with the breastfeeding dyad would be considered the identifier. The identifier is then the one who refers to the assessor. The identifier of a breastfeeding problem is someone who asks mom, quite simply, how is breastfeeding going? This is often the pediatrician or pediatric nurse practitioner, the OBGYN or certified nurse midwife, the inpatient or outpatient registered nurse, or the inpatient or outpatient IBCLC. This may also be a community breastfeeding support person, such as a La Leche League leader or a WIC breastfeeding peer counselor, or it may be the parents themselves. But whomever is the identifier of a potential problem must then be responsible for referring to the next step, the assessor. Fully and properly assessing a baby's ability to breastfeed is a complex and time-consuming undertaking, and this is best done by the International Board Certified Lactation Consultant in outpatient practice. It's also important that the one who assesses has the ability to follow up on breastfeeding, and oftentimes the one who identifies simply can't follow up or doesn't have the time or expertise to provide that long-term breastfeeding care. You are also considered in the identifier category if you're not well versed in performing a full hat lift and a full feeding assessment. The identifier may identify possible limitations in oral range of motion of a baby in one or more of 3 ways. So first and foremost, we should be getting mother's report of breastfeeding and if she's having any difficulty. And then we would look at the infant's rate of gain or ability to eat properly or having any difficulty swallowing. The Murphy maneuver is a way to identify a prominent frenulum underneath of the tongue, but looks at appearance only. And then there's the short form of the hat lift, which is a simpler and even more reliable way to identify for restriction of the tongue. So we'll go through each of these. So first, and I would argue most importantly, is a mother's report of difficulty breastfeeding. Pain. If you'll recall, in the first presentation, I harped on the importance of acknowledging a mother's pain and referring her for help. Remember, it puts her at a very high risk for quitting breastfeeding and a very high risk for perinatal mood and anxiety disorder. If a mother is using any assistive devices to breastfeed, such as a nipple shield or a pump or formula, then we want to refer her to an IBCLC. It's also really important that we not shame her for using these devices, but that we see these as a compensation for normal breastfeeding and a need for further evaluation. If a mother reports that a baby is having prolonged feedings lasting longer than, say, 40 minutes, or she's nursing for a long time and the baby is coming off the breast unsatisfied, that requires a referral. And if the baby is having excessive weight loss or poor weight gain, and this would be a newborn baby that loses greater than 10% of his birth weight, is not back to birth weight by 2 weeks, or a baby that starts to trend down in percentiles. I'll mention it again later, but I do have a suspicion that babies that slow their rate of gain between month 1 and month 2 are sometimes the babies that then or have a significant slowing in weight gain. In any of these circumstances, the next step is to refer to an outpatient IBCLC. If you would like to look for the presence of a prominent lingual frenulum, then you can use the Murphy maneuver, and you may be using this already without really knowing it. Essentially, the Murphy maneuver is inserting your finger at the rear of the baby's tongue on one side of the frenulum and sweeping across underneath of the tongue. If you feel just a small speed bump, there's most likely not a prominent lingual frenulum. If you feel a very large speed bump or almost a thick tree trunk there, then there may be an issue. If you have to jump over a fence, that the frenulum stops you midway through, or if you feel a long stretchy piano wire. So the Murphy maneuver would tell us that if there's any prominent frenulum under the tongue, it requires a further look. Some people feel that this is an appropriate way to assess for tongue ties at all, and I would disagree that this is only looking at the appearance of a prominent lingual frenulum and not in fact looking at restriction in function, which is the most important component of assessing for restriction in oral range of motion or tongue tie. If you would like to go into deeper assessment of the lingual frenulum and get a better idea of whether or not this baby has restriction in range of motion, I recommend the short form HATLIF, Hazel-Baker assessment tool for lingual frenulum function. There's been a study that has looked at the HATLIF short form and has been shown to be even more valid. And these are looking at the first 3 function items, but not getting into the trickier and more subjective sucking items, such as peristaltic roll or interior spread. There's a cutoff for 4 with the HATLIF, the short form HATLIF. And in this study, they said that less than 4 would be a good recommendation for frenotomy. And we'd like to say that if you get less than 4 on this scoring form, that you would then refer to an IBCLC. So this is the short form HATLIF. It looks at 3 reflexes that can be elicited in the baby. So the first one is lateralization, and it is eliciting the transverse reflex of the tongue. And so there's a specific way that you would sweep across the gum line and next to the tongue of the baby to watch the baby lateralize. So essentially we lateralize if you twist the tip of your tongue to your back molars. This is really important for moving solid foods around our mouths, for cleaning our back teeth, and for forming certain sounds. And so when you're eliciting this in the baby, we're looking for the tip of the tongue to follow your finger toward the back end of their gums. When a baby can't properly lateralize, they often twist their tongue. So the side edge of their tongue will come up and over, and that loses a point. So they need to be able to move both the body of their tongue and the tip of their tongue. Lift of the tongue is often best seen when the baby is crying. And the baby needs to be able to lift both the tip and the edges of her tongue to mid-mouth with her mouth wide open. So imagine that the baby has to be able to lift and drop their tongue while in a wide gape or a wide latch on the breast. And the last is extension, where we're looking for the extension of the tongue to go past the lower lip. Now, I will say that oftentimes these HATLIF components, both the long and the short HATLIF, need to be evaluated throughout the course of a breastfeeding assessment because not all babies are cooperative and will show us these movements. Extension in particular is a little tricky to elicit, and sometimes we won't see extension until the baby's resting in the car seat, let's say. Also, we can ask mom to keep an eye out for, can the baby extend the tongue past the lower lip? The baby on sucking assessment should also be extending the tongue past the gum. So you shouldn't feel the baby biting your finger at all when you're assessing for a suck. So you would score the baby from 0 to 2, and if the baby scores equal to or less than a 4, then that would be grounds for referral. Our argument would be then referral to an outpatient lactation consultant for an assessment of fit of the mouth to the breast. So in an effort to get a little bit of control over the tongue and lip tie epidemic of everybody talking about tongue or lip tie, I'd like to recommend that if you're the identifier or the assessor, since you are not diagnosing, you're not going to use the words tongue tie or lip tie. And the reason for this is because we want to minimize the confusion whether or not does this baby have a tongue or lip tie. So my recommendation is that if you suspect that the baby has a restriction in range of motion of her tongue, or if a mother asks if the baby has a tongue tie, your language sound a little bit like this. Your baby doesn't seem to be moving his tongue the way he should be. I'd like you to see somebody who can take a closer look at it and help you with breastfeeding or bottle feeding. And the mother's going to push you and she's going to say, so does my baby have a tongue or lip tie? And hopefully we can circle back and say, well, the baby might, but I'd like to be certain and look at all the contributing factors before we make a diagnosis. I know you've seen a lot about this on the internet, and I know you're really struggling with breastfeeding, and I'm here to help you. But I don't want to proceed with any type of procedure until you and the baby have had a full feeding assessment. And don't be surprised if the mother comes back with, so does my baby have a tongue or lip tie? So the very helpful identifier, the person who says first, this mom's having trouble, this mom's having pain, this baby's not gaining, or mom is asking if the baby has a tongue or lip tie, would then refer to the outpatient lactation consultants. Now, there's also a need for babies who are exclusively bottle feeding or formula feeding to have suck dysfunction assessed. And this is where there's a little bit of a crossover here with our speech language pathologist who specializes in infant feeding. So if we have a baby who's exclusively formula feeding, the assessment may be done by a SLP with infant feeding expertise. So the assessment is done by the qualified outpatient IBCLC. And this isn't because I am preferential to outpatient IBCLCs, but the inpatient IBCLC would act as the identifier here. Because she cannot properly assess milk transfer because milk's not in, because she oftentimes can't reliably follow up because of her role as an inpatient consultant, we would need an outpatient consultant who can complete a full assessment of the appearance, function, and fit of breastfeeding, who can refer to a revisionist if the baby fails the hat lift, and who's ready and prepared with the habilitation team to coordinate care. The outpatient lactation consultant is responsible for caring for this breastfeeding dyad until competent breastfeeding or stability is achieved. So the identifier should not be sending to the diagnostician. The identifier should not be going straight to the revisionist provider. The assessment person should. So when the lactation consultant deems that the baby has failed the hat lift and that breastfeeding is not going appropriately and there may be a restriction in the tongue tie, then we go to the diagnosis team, and the diagnosis team is insistent upon that baby going back to the assessment team to then start habilitation. So how do we properly assess? We have to look at appearance, which is completed by the full hat lift score, function, which is completed by the full hat lift score, and fit, which is how this baby mouth fits on this maternal breast. Breasts are very different in elasticity and in size. And we need to do a complete breastfeeding assessment beginning to end, including transfer weighs with a highly sensitive baby weigh scale. All three of these things must be assessed in order for us to say that this is a full and complete assessment. A complete breastfeeding assessment by an outpatient IBCLC is quite comprehensive and time consuming. The first appointment takes 90 minutes and subsequent appointments take 60 minutes. And that's because we're going through a full subjective history, mom's medical history, and pregnancy and birth history. We spend a lot of time with how was your birth? Women who had difficult, traumatic births, this is really an opportunity for us to develop rapport with her and determine where there might be some hot spots in her story that we might circle back to that could put her at risk for PMADs. We do a full physical assessment on mom, including integumentary status of her breasts and nipples, looking for plug ducts and mastitis. We look at the breast drainage, her milk supply, and we do a complete set of vital signs. We do a mental health assessment on all our moms at the first or second appointment, and we prefer the Edinburgh score. We use a social assessment to look at the support network and her plans for return to work. We can't possibly make a care plan for breastfeeding without understanding the dynamics in her home. What's her maternity leave? What's her partner's maternity leave? Does she have support from family? Does she have the resources to pay for certain habilitation services? So we need to know these things. Next, we go on to the physical assessment of the baby. We look at a head-to-toe assessment. All of us are registered nurses at our office, so we're fully qualified to do a complete head-to-toe assessment, including hydration status, jaundice status, the baby's output, feeding patterns, and then we look at trends in weight and rate of gain. And then we complete an oral assessment on the baby. When assessing for the appearance of the lingual frenum, we're looking at the baby from top down. So here's an example of how we position our babies when we're assessing the lingual frenulum. You really can't do a proper assessment at the attachment site of the tip, the attachment site to the alveolar ridge, without being able to properly see. So we prefer to swaddle our babies. Their head is up at our chest, and we have a headlamp. We wear gloves, of course. And the hat lift tool asks for us to look at attachment to the tip, attachment to the alveolar ridge, length of the frenulum, elasticity of the frenulum, and the appearance of a cleft or heart shape in the tip of the tongue. If you're assessing the appearance of a lingual frenulum, this is the position that you should be in to be looking. The second half of the hat lift tool looks at function, and function is often done in pieces, as I mentioned earlier. So we elicit reflexes like the transverse tongue reflex for lateralization and the tongue extrusion reflex for extension, but anybody who knows a newborn baby knows they're generally not as cooperative as we'd like them to be. So elements like peristaltic roll, sucking on a finger, and cupping, sucking on a finger, are best done when the baby's hungry and interested in sucking. Elements like extension we might see as the baby is latching on and goes to take a wide gape. And then elements like snap back we have to look at while the baby is feeding. So we often end up completing a functional portion of the hat lift tool throughout the visit. And by the way, this picture that you're looking at right now is the transverse tongue reflex, and you can actually see the baby twisting her tongue to get to the examiner's finger. We can assess a good bit of function just by observing a baby crying. When a baby cries, they lift their tongue, and we can see if with a wide open crying mouth, they can get their tongue up as far as they should. So that baby on the left is the baby from the original picture, and a lot of people probably were looking at that little frenulum underneath her lip or the white spot under her tongue, when someone who knows what they're looking for would actually be looking for the lift. So we're looking for the tip of the tongue's ability to come to mid-mouth with the mouth wide open. So the baby on the left is actually showing us some pretty excellent lift. The baby on the right is showing us that she can only lift the side edges of her mouth and not the tip of her tongue. So that baby might actually have a risk for limited function in her tongue. So spend some time watching babies cry and notice how they move their tongue. So it turns out that a baby mouth only has to breastfeed on one set of boobs. If we're not doing a complete breastfeeding assessment, we can't really know how well that mouth is working. Because breasts are so different, we have to look at that mother's breast with this baby's mouth. When we do a complete breastfeeding assessment, we're not only looking at a thorough picture of the milk status, but we're looking at the anatomy fit of mouth to nipple. So does mom have inelastic breast tissue? Does she have flat or reverted nipples? Does she have bulbous or large nipples? When we put that infant mouth on that mother's anatomy, then we're looking at the efficiency and efficacy of milk transfer. So how is the baby able to move milk with her mouth and mom's breast? And then we're also assessing from the maternal understanding of infant cues. Does the mom know the difference between a deep latch and a shallow latch, a painful latch and a comfortable latch, or the infant being satisfied or not? It is key that the lactation consultant understand positioning and latching. It seems that some lactation consultants are on a mission to find a tongue tie rather than on a mission to find how to make breastfeeding work. So oftentimes when we look at anatomy of a mother's breast, we can use different types of positioning and holds in order to compensate for the baby's lack of range of motion. But it isn't the lactation consultant who needs to latch the baby when mom goes home, right? It's the mom. So not only does the lactation consultant have to get the baby into a different position, but the mom needs to be able to recreate it. If a mom can't return demonstration of skills learned, then it's a pointless exercise. So we need to both be able to find that proper position and have mom recreate it. So a complete breastfeeding assessment looks at appearance and function and fit. It must include all three. And I would like to point out that it is not within the scope of practice for an IBCLC or a registered nurse to diagnose the presence or absence of a tongue tie. I'll say that again. It is not within the scope of an IBCLC to diagnose the presence or absence of a tongue tie, but rather she may tell the parents that the infant may have a limitation in oral range of motion and refer to a specialist. And this is a big sticky widget, and I am not Katie Madden saying that I've never said tongue tie to a patient, but I and my partners are actively trying to not say the words because, as I'll say a little later on, it is the role of the specialist who looks at frenulums and who treats frenulums to be the one to determine if there is a tongue tie or not. It is our job to do a complete breastfeeding assessment and look at if the infant has limited range of motion or if the fit of mouth to nipple is not quite right. We round out this breastfeeding assessment with a written care plan for mom, baby, and the dyad. We use written materials, both standard and customized to the circumstances. So moms will get a folder of material that includes everything from plug ducts to fussy night times to pumping and bottle feeding, and also a handwritten care plan. These new postpartum moms have a very limited memory. Most patients have a limited memory, but our sleep-deprived, overwhelmed moms have little to no memory. So we write down every single instruction for these parents to take home. We send a report to the pediatrician to let them know what we found and who we're referring to and what our care plan is. And then we coordinate the referral services and peer support. And then we have at least one follow-up visit, often more. Often it's half a dozen visits because we will not let a mother out of our care until she is at a point of breastfeeding competence or overall stability, which may include weaning. Every practice should have a protocol for the care of the newborn with a suspected restriction in range of motion. Our practice's protocol is included in the downloadable materials where you got this PowerPoint, and I would invite you to please feel free to amend it for your practice. But this is a hot button issue and it's widely debated, and so I think it's important that every practice have a clear written protocol for how they're dealt with. So before I move on to diagnosis, I'd like to mention the baby who is doing well with breastfeeding and fails the hat lift, or the baby whose parents opt to not revise. So what about the baby that is gaining well and clearly has a restriction in range of motion? Well, there's a lot more to breastfeeding than a well-fed baby. My first question is breastfeeding really going well? Just because mom's not having pain or just because the baby's gaining weight doesn't necessarily mean it's going well. So if we're having prolonged feedings or a baby that's coughing or sputtering or a lot of throw up or acid reflux, then maybe we should be taking a closer look at if breastfeeding is actually going well. What we have noticed is that moms with a really ample milk supply in the early weeks of breastfeeding, that may actually be masking the effects of suck dysfunction. We have a funny expression called living off the letdown, which is the baby that gets onto the breast, stimulates a letdown with just a little bit of sucking, or sometimes the mom will just let down, looking at the baby, and then the baby can barely latch and just drinks, right? So this baby is just kind of opening up his throat and chugging. This baby doesn't have to use his tongue very much, so mom will most likely not have nipple pain, and the baby will seem to gain beautifully because they don't have to elicit that full suction. The problem is that when milk supply regulates around 6 to 8 weeks or sometimes a little later, and the baby must then engage full suction, now we can sometimes have problems. So we then have a baby that can no longer drain the breast effectively or is starting to do nipple damage because he's using the suck that he has. We're suspicious that this is sometimes responsible for the 2 to 4 month weight drop off. So if you've noticed in your practice that you have a baby that gains really, really well at 1 month, gains okay at 2 months, but not as well as 1 month. And then at the 4 month checkup really drops off the percentiles. I'm suspicious that this is because there was a vicious cycle of the baby not nursing well and the supply decreasing and the baby not being able to bring it back up. So if we have a baby that fails the hat lift and the parents opt to not revise, we encourage check-in, especially if there was a drop off from 1 to 2 months. So by all means, like, we are not going to push a parent to do any sort of revision or surgery if they don't want to, but we do have a responsibility to keep a close eye on this couplet because we know that the baby can't move the tongue as effectively as he would if that frenulum wasn't restricting his movement. So I do encourage you, even if you identify a tongue tie and the mom's not having any problems, to still connect her to lactation so we can follow her long term. So why do we want an IBCLC before diagnosis? Why can't the pediatrician just find the tongue tie and send to the revisionist? Why can't the mom just self-diagnose online and then go to the dentist? Well, it's happening a lot, and ideally we'd like to decrease the amount of self-seeking care. When we self-seek care, there's the potential for unnecessary revision. If the mom self-seeks care, then we don't have anybody treating underlying issues, and there's almost always an underlying issue with the tongue or lip tie. If the baby is not effectively breastfeeding, then we have issues such as low milk supply, nipple trauma, infection, or poor infant weight gain. And those are things that need to be managed, mom and lactation consultant. There is often moms are using support tools, right? A nipple shield or bottles, and these can become particularly exhausting or burdensome, and it can be really scary for moms to pull back from supplemental bottles. So she deserves to have a team member. She needs support before and after the procedure. There is a huge misconception out there that revising a tongue or lip tie just fixes everything. And certainly there are cases where a revision fixes things pretty quickly, but oftentimes it's more complicated than that. And she's going to need education and support before the procedure and education and support afterwards. It is a surgery, and we need pre and post-op care. Shortly after the visit, we need to have a mom have a resource of where she's going to go if there's a new onset of breastfeeding issues. Again, we have to do things like relearn how to suck and strengthen supporting muscles through tummy time. And she certainly is going to need emotional support. And it is the IBCLC's job to coordinate this habilitation care. It's also important that the baby be seen by an IBCLC before the revision provider. Because I think it's important that we're taking consideration that the baby is a growing, thriving baby that's ideally back to birth weight. There are certainly circumstances where babies have revisions of tongue ties before they're back to birth weight, but we have to be really careful because in our experience, there are a lot of babies that will not directly latch or feed well for the first 24 hours after the procedure. So if we have a baby that's borderline, failure to thrive or not well hydrated, we can't afford 24 hours of not eating. With our patients, we do preoperatory teaching that includes the possibility of breast refusal for 24 hours. It requires a lot more vacuum to directly latch onto the breast than it does to the bottle, so it can become comfortable for a baby to nurse for the first 24 hours. And we want moms to know that this is a possibility, so we encourage parents to pump and have some bottles at the ready before the procedure and have practiced a bottle at least once. We do not want to get into a situation where we have a baby that won't latch onto the breast and has never taken a bottle before. It's often self-limiting that the baby won't relatch after a revision and lasts about 24 hours, and we want parents to know about this before the procedure. Even though we're not diagnosing tongue or lip tie in the office, we do have a suspicion of restricted range of motion. So when we make a referral to our revision providers, we teach as if the procedure is going to be done. The reason for this is because this is the most opportune point for them to learn. They're in our office where they feel comfortable and safe, and they're not under that stress of, is my baby about to have a surgical procedure? We're able to demonstrate the post-wound care, the lifts and sweeps, with an intact frenulum and have parents return that demonstration. So that's a really nice thing to do the exercises without the wound being there, because the parents can see that babies in general don't like fingers in their mouth. It's not just that there's a wound there. We send parents with written materials about the procedure, about pumping and having bottles ahead of time. And so we go through all of those materials in our office. And then we also discuss a phenomenon that we've called post-revision remorse. This is in the links on your downloadable page in the resources for tongue ties. We find that a lot of moms have a knee-jerk reaction of regret right after doing the procedure. And of course they do. Their babies are sore and there's a wound in their mouth. And so we want to let moms know that it's really normal to have remorse right afterwards, and that doesn't mean she made the wrong decision. So once we deem a baby to have limitation in range of motion, we will refer to a diagnostician. The revisionist is the one that makes a diagnosis. The revisionist only performs the revision with a complete clinical examination and a written report from the IBCLC and mother's history and report of symptoms. So there are plenty of dentists or ENTs in the community that will do a revision simply based upon visual inspection. And I'm not saying that this is wrong, but I think that it is contributing to the over treatment of tongue or lip ties and the under success or less than ideal success of frenectomies. And so we have formed a relationship with Pike Creek Dental where they will only see mothers for an evaluation if they have an established relationship with an IBCLC. Once the dentist is able to read the written report by the IBCLC and then do a clinical examination and talk to mom, then we have a better picture of what's going on, and the dentist can make a more thorough assessment and diagnosis and then determine if the frenectomy is needed. We have a number of highly skilled revisionists in our tri-state area in Wilmington, Delaware. However, we've chosen to primarily partner with Dr. Green and Dr. Robinson at Pike Creek Dental. We have together created a program where the dentist will only see patients for an evaluation of tongue or lip tie if they've first seen an IBCLC. We believe that this relationship helps emphasize the importance of the integrative team and helps decrease the rate of people self-diagnosing and self-seeking care. We enjoy supporting a small Delaware business, and Dr. Green and Dr. Robinson have personal experience with breastfeeding themselves and understand the complex dynamics that go into this decision. Parents can expect a 1-hour-long appointment at Dr. Green and Dr. Robinson's office, regardless of whether the parents have the procedure done or not. About 45 minutes of this is spent in discussion time. Dr. Green and Dr. Robinson go through a lot of similar history that we go through, and a lot of this is rapport building. It's having empathy for the mom and for what's going on. It's discussing the goals and expectations of this procedure. We by no means will imply that this is a fix-all, cure-all procedure, and Dr. Green and Dr. Robinson are adamant about that the patient understand that. And then about a portion of that 45-minute time is spent with evaluation and diagnosis. And again, you're going to see that knee-to-knee assessment or at the head of the baby assessment with a light so that we can get a full picture of the range of motion of the tongue. If the dentist diagnoses a tongue and/or lip tie, they will offer the procedure to the patient the same day. Dr. Green and Dr. Robinson will go into detailed explanation of the procedure, the safety, and how the laser works, and complete an informed consent. Before the procedure, they'll review what to expect immediately postoperatively, how to manage pain, and what to expect in the following days. Again, this is all done before the procedure is done, when the parents are a little bit better able to hear the information. The dentist will also review those same exercises and lifts and sweeps that the lactation consultant went over, and these are written and verbal. So again, we're repeating a lot of the same teaching to make sure that parents hear everything that we're trying to get through to them and they understand it, and all of it is written for their reference. The procedure itself is quite quick. The office is set up as a surgical suite with drapes, gowns, and laser eye protection. The procedure itself takes only about 2 minutes with 20 seconds of laser treatment time. There are 2 assistants in the room, the baby is swaddled, and we take utmost priority in making sure that the baby is safe and stabilized. At Pike Creek Dental, parents are welcome to stay in the room or they may leave. It's totally up to them. Dr. Green and Dr. Robinson have extensive training in the use of the water lathe for laser dentistry in both adults and infants. They believe that this is the preferred revision tool, and we tend to agree at Balanced Breastfeeding. The benefits of using the laser tool for oral surgeries, revision of oral structures, is hemostasis. So we see little to no bleeding. We see less trauma of unnecessary tissues. We see very little swelling, and we see a much lower risk of infection as the water has a bactericidal effect. I've been working with parents who've had revisions for over a decade, and I've seen both instrumental release with scissors, and the outcomes are significantly different. We see much less bleeding and swelling, much less rehealing, and much less nearby tissue trauma with the laser versus the instrumental technique of releasing the frenulum. The same post-op care that was taught by the IBCLC prior to the revision appointment is then taught again to the parents by the revisionist. This is done before and after the procedure, and it is in both written and oral form. The doctor also gives the patient their personal cell phone. Dr. Green and Dr. Robinson have decided to do this since it is a very specific population, and these parents are often very worried and need someone to contact in the early days post-procedure. If they haven't heard from the parent, Dr. Green and Dr. Robinson are sure to reach out to the parent each day in the few days following the procedure to see how things are going. Because of the importance of healing by secondary intention and active wound management in the healing of a frenotomy wound, Pike Creek Dental and Balanced Breastfeeding have developed a protocol for post-op care to inspect the wound and make sure that it is healing properly. We have a policy that post-procedure, the patient is to follow up with the lactation consultant 3 to 5 days after the procedure. And at that point, we check the wound, make sure it's healing properly, and make sure the parents can return demonstration of the post-operative lifts. The patient then follows up with the lactation consultant about a week post-procedure, and then continues to follow up with lactation as long as necessary, and then follows up at Pike Creek Dental 2 weeks after the procedure. The 2-week follow-up vision with the revisionist is an opportunity for the dentist to go through the whole operative and post-operative experience with the patient and see how comfortable they were with the entire experience. They'll review how mom and dad coped with the procedure, how baby coped with the procedure, and how comfortable they were with the exercises, lifts, and sweeps. This is also an opportunity to reinforce the importance of following up with the lactation consultant if there are still breastfeeding problems. Of course, there's a clinical evaluation of the actual revision site by the dentist, and in some circumstances, if the frenulum has overgrown or regrown, there's a re-revision. The last component of the integrative team is the habilitation team. The habilitation team supports both baby's physical recovery from the revision procedure and also the mother's emotional well-being. As we know that mothers who are having pain or breastfeeding difficulty are at a high risk for PMADs, the mental health provider is an important component of this team. The infant feeding specialist can often be pretty important if we have a baby that continues to have suck dysfunction post-procedure. We also encourage moms to be part of a live and potentially also virtual peer support group. At the birth center every Friday we have a free drop-in breastfeeding support group, which is always expertly moderated by one of our lactation consultants. And this is an opportunity not only to get your baby's wound checked or to get a weight check, but also to meet other mothers who are struggling with different types of breastfeeding issues. The peer support community is critical for moms who are going through any breastfeeding difficulty, but in particular tongue and lip tie, because they have others who have recently gone through this experience, and nobody knows the experience quite like another mother. And then, of course, we have the very important role of the body workers. We use the expression habilitation instead of rehabilitation because these babies could never suck properly in the first place. So rehabilitating is returning to function. Habilitating is to gain the function in the first place. So there's two components we use in our practice. The first is oral myofunctional therapy, which is essentially suck training and some gentle oral stretching. So when we use our hat lift tool and we look at the limitations in function, we also know where the baby needs to improve function after the revision. For instance, if the baby was not lateralizing his tongue before the revision, we now need to work on lateralization exercises, which is simply teaching the mother how to elicit the transverse reflex. So each baby will be given a customized myofunctional therapy plan, which may include sucking exercises or strengthening exercises. And that is done by the IBCLCs and sometimes the SLPs. We have a body worker that we work closely with. Her name is Colleen McLaughlin, and she is a craniosacral therapist who also does expert care in myofascial release. So she's with us in our office a few days a week, and she sees our babies before and after revision to make sure that the fascia isn't still remembering that the tongue tie is there. So she does a really beautiful job of gently massaging and using acupressure to release tight or kinked fascia in the baby's body. And the results are pretty impressive. We also use body work for babies who have positional issues such as mild torticollis or preferentialism, or babies that have some misshaping of their head from their lie in utero, which can all affect breastfeeding. Remember, this mama is at high risk for PMADs because of her pain, because of her breastfeeding difficulty. So I remind you to see her and feel her pain and screen her. It's really easy to give an Edinburgh score in your office. You can get it right offline. And if she scores higher than is appropriate, she should be referred to the perinatal mood specialist. We have an amazing women's emotional wellness team at Christiana Hospital and a number of providers in our community that specialize in perinatal mental health. We can no longer see a frenulum as something that stands in the way of breastfeeding and needs to be clipped. Rather, we need to look at the breastfeeding dyad as a whole and see the mother and the baby as unique individuals who have varying needs. It is the role of the entire integrative care team to take care of this mother and baby. That includes the identification team, the assessment team, the diagnosis team, and the habilitation team. I hope that after today's talk, you can understand a little bit better the dynamics of this complex situation and your role in helping mothers and babies successfully achieve their breastfeeding goals. If you have any questions, please don't hesitate to contact me, katie@balancedbreastfeeding.com, for further discussion on this topic. After this last slide, you'll see a bonus slide about the importance of airway and a review of the evidence. Thank you so much for taking the time to learn about tongue and lip ties, and I hope that you can incorporate this into your practice. Bye-bye. This is a really excellent video that reviews the importance of nasal breathing over mouth breathing. What we didn't go into a lot of detail about today in this talk is the importance of the tongue in developing the airway and developing the palate. And Dr. Ryan Robinson is particularly interested in this because at Pike Creek Dental, he originally was doing frenectomies of the tongue for sleep apnea, and he still does that pretty regularly. So please take the time to watch this video to understand the importance of nose breathing over mouth breathing and understand that when there's a tongue tie, it can very much impact things other than breastfeeding. However, we can't use those reasons in our decision-making process for revision. We have to be looking at the tongue and lip tie and the dynamic right in front of us at that time. So what does the good evidence say? There's some fair evidence out there in both a prospective cohort study and in an evaluation with ultrasound that tells us some really interesting things about the release of tongue and lip ties. Gahiri is a leader in the frenectomy world when it comes to breastfeeding and tongue ties. And he did a study in 2017 that was a prospective cohort study that found that there was significant improvement in breastfeeding at 1 week and 1 month postoperatively. Geddes in 2008 did ultrasound of the baby's tongue before and after resection of the tongue tie and found that there was a improved flow of milk. There was better attachment and there was less maternal pain after frenectomy. These are not randomized controlled studies, however, but these are two studies that stand in the category of revising tongue ties creates better breastfeeding results. So what does the best evidence say? Cochrane reviewed the literature, found that there were 5 randomized trials that could be included, and all of them had serious shortcomings. No studies found that there were adverse outcomes of frenotomy procedures, which I think is really important to note. And no study was able to look at the long-term success of breastfeeding. And so we have this kind of problematic statement that has been taken by some providers. So the Cochrane review said that a surgical release does not consistently improve infant feeding, but is likely to improve maternal nipple pain. And for some, we've taken this as women are revising their baby's tongues just because their nipples hurt. And I will refer you back to my pictures of traumatized nipples and remind you that nipple pain is not something that whiny mothers complain about. It is a real and significant issue, and it is not normal. What we haven't connected the dots on yet is that nipple trauma, nipple pain, comes from dysfunctional sucking. Nipple pain comes from dysfunctional sucking, and dysfunctional sucking leads to inappropriate drainage of the breasts and overall could potentially lead to breastfeeding failure. So the problem with the research right now is that we haven't basically validated the fact that nipple pain means there's a breastfeeding problem, and rather we're putting it in the category of mothers are selfish and want to help themselves. So I ask that you look at the next level of what does nipple pain mean, and we know from today's lecture that that means that there is suck dysfunction and difficulty transferring from the breast.